Hi, good morning. It's so nice to take class after time. I think just 3 months. And conversation. So I'm not even going to see your faces, but then it feels really good to take a class. I hope all of you are doing well and you're staying safe at home. Be safe. I don't think so. The Karnataka government is going to make you all come here for a long time. So I think this is how we're going to meet online. Today's class is about the endocrine system. All of you have learned about the endocrine system uh, in physiology and the working of the endocrine system also in biochemistry. Okay, all the mechanism and everything. What we're going to teach here is the disorders or the pathology part of the endocrine system. Today's class, the first few slides are basically how the endocrine system is going to work, what all constitutes the endocrine system, and how this endocrine system is so beautifully made in such a way that there is a positive feedback, there is a negative feedback, and if one goes high, how the other one kind of brings it down, the hormonal part of it. And all of us know that hormones can play they can do wonders, or they can even create havoc in our bodies and in our system. So today's class we're going to in general study about endocrine system and the different type of signaling and everything, and I'll be starting about pituitary. Okay. I also want to let you know details of it from uh, because the working of the endocrine system and how the signaling and all is very beautifully, the first introduction part of it is very beautiful in Harsh Mohan. But the tumors and the other mechanisms and about thyroid and all is given very well in Robbins. So today's class I've taken most of it from Harsh Mohan because it's the introduction. Introduction means it's something that you've already learned, which is going to revise. Okay. So what is this endocrine system? It's highly integrated and it is widely distributed group of organs. And this endocrine system, it orchestras a state of metabolic equilibrium. What do you mean by metabolic equilibrium? It means that these hormones have to be, in a sync so that everything works well. Okay. And in homeostasis among various organs of the body. And endocrine system works by signaling. Okay, how does it signal? There are three types of signaling. One is the autocrine signaling, the paracrine signaling, or the endocrine signaling. Okay, so this endocrine signaling, the secreted molecules which are from the organs, which are the endocrine organs, are called as hormones. And what these hormones do is they are act on the target cells, which are distant from the site of synthesis. Okay, and the endocrine hormone is frequently carried by blood from the site of uh, the endocrine or hormone is frequently carried by blood from its site to the release. Okay, so that's why whenever we have any problems with the hormones, for example, we suspect a thyroid problem or we suspect some hormonal problem, what we do is we can easily get some blood tests done, and we can figure out if we have any hormonal deficiency or hormonal excess. Okay, so since the hormone is frequently carried by blood from the site where it's formed, that is released, to its target organ where it's supposed to act. What all constitutes the endocrine system? Endocrine system actually, the pituitary gland, the adrenal gland, the thyroid and the parathyroid glands, the gonads, that is the testis and the ovary, because they also secrete hormones, and the pancreatic islets. Okay, pancreatic islets can come under neuroendocrine system also. and they come under endocrine system, endocrine and neuroendocrine system. Okay, so I'll be telling you about what is neuroendocrine. So all these together, the pituitary, adrenal, thyroid, and the parathyroid, gonads, and the pancreas, all these constitute the endocrine organ. So what do these endocrine organs do? They secrete hormones, and they are released, and they actually act on the target tissues. Okay, and what they do, we'll tell you when I take the respective systems. Neuroendocrine system. Okay, what is neuroendocrine? Endocrine, I told you, is something where it secretes hormones. Then neuro system is something to do with the nervous system. So when you combine these two together, it forms the neuroendocrine system. Okay, so the neuroendocrine system is a link between the endocrine and the nervous system, and the cells of the neuroendocrine systems are neuroendocrine cells, and they secrete polypeptides. Okay, they're also called as APUD system. Because of this biochemical property, the neuroendocrine system cells are also called as APUD cell system. Okay, so what are the cells of the neuroendocrine system? The neuroendocrine system has the neuroendocrine cells. These neuroendocrine cells can be seen in gastric tissue, intestinal mucosa, and these elaborate some hormones called as peptide hormones. All this is there in your textbook. I'm just like giving you an introduction to what are endocrine organs, what are neuroendocrine organs. Okay, so neuroganglia cells lie in the ganglia cells in the sympathetic chain, and these neuroganglia cells, these elaborate amines. Okay, adrenal medulla, they elaborate epinephrine and norepinephrine. And the cells in the thyroid are also some of the cells in the thyroid called as the parafollicular C cells. They are of the neuroendocrine system, and they secrete calcitonin. Then the some of the cells in the islets of Langerhans, okay, they belong to both the endocrine and the neuroendocrine system. That is the secretion of insulin. Why neuroendocrine system? Because it needs a stimulus of the nervous system. There will be some stimulus from the nervous system for this endocrine organ to act. Okay, and there are some special cells in the heart. Okay, in the left atrium of the heart, and they secrete a thing called as atrial natriuretic peptide. Okay, these are salt losing hormones, and that also belongs to the neuroendocrine system. Are divided into five major on the site of interaction on the target cells, and the other one is depending on the receptors, whether they are cell membrane receptors or nuclear receptors. Cell membrane means the receptors of these hormones will be present on the cell membrane. Nuclear receptors means they will be present inside the cell on the nuclear membrane. Obviously, the nucleus is present inside the cell, and the nucleus will also have a membrane called as nuclear membrane, and these receptors are present inside the or on top of the nuclear membrane. um, the synthesis of these hormones are all like so beautifully orchestrated that there's first transcription which leads to mRNA formation. So what does this mRNA do? All of you have learned in biochemistry. It helps in protein synthesis. After protein synthesis, there is translational, post-translational protein processing, and just hold on, please. Then there's intracellular sorting or the membrane integration. Okay, so as soon as the membrane is integrated, after there is a transformational change of the membrane, there's membrane checking. Okay, so I told you there are many groups. Group 1 has amino acid derivatives and small neuropeptides. These group belong to the cell surface membrane receptors. So the major hormones which are depending on the receptors which are present on the cell surface are the thyroid hormones, catecholamines, then gonadotrophin releasing hormone, thyrotrophin releasing hormone, somatostatin, vasopressin, etc. So these are the hormones which act based on the receptors which are present on the cell surface. So what are these hormones which act on the nuclear receptors? That is, within the cell, on the nuclear membrane, there will be receptors. So these hormones actually act on the in nuclear receptors. These are very large proteins like insulin, luteinizing hormone, parathormone, etc. Some steroid hormones secreted by our ovaries like estrogen, then cortisol, vitamin derivatives like vitamin D, retinol, etc. Okay. So while they listed, make sure that the cells have certain functions. What are these functions? They're growth and differentiation of cells. Okay, so all of us know that when pituitary hormone is not secreted adequately or it's absent, there will be growth retardation. All of you have learned that in your physiology. So growth and differentiation of cells occurs by pituitary hormones, thyroid and parathyroid, and some steroid hormones. All of you know that even when thyroid is very, very deficient, like when the mother has very low thyroid during her pregnancy, they are given extra synthetic hormones so that the child should not be a cretin. Okay. Then it also helps, this hormones also helps in maintenance of homeostasis, like the thyroid hormones regulate the basal metabolic rate. Then the parathormone, mineralocorticoids, vasopressin, insulin, all of them maintain the homeostasis. For example, the insulin. Okay, so whatever food we eat, okay, it's converted to sugars, and sugars are or glucose, and that is taken up by all the cell for the normal functioning. Okay, so insulin along with other hormones secreted by the pancreas have to act in sync so that they maintain the homeostasis. Some of these hormones which are produced by the testis and the ovaries also help in reproduction. Okay, like sexual development, sexual activity, maintenance of pregnancy, fetal development, menopause, etc. So these hormones, they can't go on being released. Okay, to be some catastrophic changes. So because of that, they have if they're too much, so there'll be a negative feedback. If there is very little, there'll be a positive feedback. So all these endocrine glands have both positive and negative feedback control system. They regulate the release of the hormone in such a way that the levels always remain within a range. Okay, so it shouldn't be too much, it shouldn't be too little. It's always in sync in such a way that they have both negative and positive feedback control system. Okay, and the most important negative and positive feedback control system for some majority of the hormone is something called as hypothalamic pituitary hormone axis for different hormones. Okay, I'll be telling you which are all the hormones which have this hypothalamic pituitary hormone axis. This the stimulatory or regulatory action by endocrine hormones may follow paracrine or autocrine pathways. So this what is paracrine and what is autocrine? Paracrine means whenever the hormones or the stimulation regulatory factor is released, it acts on a cell which is away from the place where it is released or some adjacent cell. Whereas autocrine is the regulatory action occurs on the same cell that produce the hormone. Okay, so that is the difference between paracrine and autocrine action. So if you see this picture, this is also from Harsh Mohan. Okay, this is a picture which shows the hypothalamic pituitary axis. So many organs act according to this negative and positive feedback. It has a negative and positive feedback for hypothalamic pituitary ovarian gland, thyroid and the parathyroid. Okay, the testis also. There are some like pancreas, they don't act on the hypothalamus, they act only on the anterior pituitary. Okay, so what happens when these hormones are not secreted normally? Okay, the hormones have to be secreted, I told you, in adequate amounts. It can't be very little, it can't be too much. So when it's very little, it's called as hypofunction or deficiency of hormones. It can be because of various causes. It can be the organ which is forming and releasing this hormones itself can be destructed, okay, like inflammatory conditions, autoimmune conditions, infections. Sometimes it can be because of overproduction of hormones. We ourselves, iatrogenic, that is, they're producing too much and it's causing adverse effects, so we surgically remove these hormones. Sometimes because of some radiation they get damaged. In all such conditions, what happens, the hormones are not produced normally, so this deficiency of hormones. Sometimes this hormone are produced in excess, okay, that is called as functioning or excess of hormone. It can be because of some tumors, it can be because of hypoplasia of the endocrine gland which secretes it, or it can be because of ectopic. Ectopic means what? In a site where it is not supposed to be. Okay, suppose for example, um, thyroid hormones are secreted by obviously thyroid gland, but sometimes there's something called as struma ovary, where there'll be functioning thyroid gland present in the ovary, okay, in a tumor of the ovary, where um, they'll be actively secreting, they'll be functional, okay, so they'll be secreting. So in such cases, because of ectopic hormone production, there'll be excess of hormones, and that will also cause problems, okay. Then because of some autoimmune infections or autoimmune conditions like thyroiditis, okay, sometimes it can cause deficiency of hormones, sometimes it can cause overproduction of hormones, or it can be because of side effects of some drugs which have been for treating something else. We'll give them hormone supplements because of which they can have hyperfunctioning of some. It can also be because of hormone resistance, okay. Hormone resistance can be adequate or excess because of there is resistance of the receptors, okay. It can be mutations, it can be some genetic defects. The nuclear receptors can be problematic. The cell membrane receptors can be problematic, okay. So sometimes, even though the hormones are being released by the endocrine organs, the receptors which have to they help in the uptake of these hormones, they can be resistant to these hormones. In such cases also, there won't be any effect of these hormones. Okay, so this was in general about all the endocrine glands. So let me revise. Okay, endocrine glands are like pituitary, then adrenals, thyroid, parathyroid, ovary. Okay, all these are organs. Then pancreas. Okay, the endocrine part of pancreas. Pancreas is an organ which has both the exocrine part and the endocrine part. So here we'll be only dealing in the endocrine system. We'll be only dealing with the endocrine part of pancreas. Okay, the exocrine part of pancreas will be with along with the either hepatobiliary system or with PIT. And so all of you know that pituitary gland is very, very small. Okay, in an adult it can weigh 500 milligrams. Like milligrams means what? It's like 500 milligram is not even like 1 gram. Like a small tablet that you all take, the small white tablet, it will be like that small. Okay, so it's very small. In that also, in women it is slightly heavier. And where is it situated? It is situated in a small hollow cavity at the base of the brain called as sella turcica. Okay, this sella turcica is formed like a scooped out part in the a bone called as sphenoid bone. And this hypophysis has two parts. Okay, it has anterior lobe called as adenohypophysis and the posterior lobe called as neurohypophysis. So post anterior lobe secretes a certain number of hormones and the posterior lobe secretes a certain number of hormones. So whichever gland I'm going to take from now on, like the pituitary gland or the adrenal gland, everything I'll be telling about the normal structure and what all hormones it secretes, and then we'll go about hyposecretion, hyper secretion, and the tumors that are associated with that particular gland. Okay, so this is how my class today's pituitary gland will also be. Hyposecretion of pituitary, what happens, what are all the conditions which leads to the hyposecretion, what are all the effects of the hypersecretion of pituitary gland, and what can be the tumors of pituitary gland. Okay, so I told you it has two lobes, the anterior lobe, called as the adenohypophysis and the posterior lobe called as the neurohypophysis. Anterior lobe okay, which is formed from the rat case doesn't have any connection with the brain or the brain. Okay, so adenohypophysis has no direct neural connection, but it has indirect connection through the capillary portal circulation. So it receives the blood which has already passed through the hypothalamus. So it only has a connection of blood, but it is not directly connected to the brain. Okay, the posterior lobe, as the name itself suggests, is called as neurohypophysis. It is a downgrowth from the primitive neural tissue. Okay, so there are two parts: anterior lobe called as the adenohypophysis and the posterior lobe called as the neurohypophysis. Anterior lobe has no direct connection with a neural connection, and it only has connection through the blood which goes it circulates from the hypothalamus and it comes to the pituitary. Whereas the posterior lobe is just a downward growth from the primitive neural tissue, so it has no direct connection with the hypothalamus. So when the blood is flowing to the anterior lobe, and you can see that it has absolutely no connection with the hypothalamus. Whereas the blue part, which is above, called as the hypothalamus, you can also see my pointer. Okay, it comes down as an output called as the posterior posterior lobe or the neurohypophysis. Okay, so all this anterior lobe, posterior lobe, everything has positive and negative feedback mechanism for the hormones that it releases. Okay, so let's come to anterior lobe. Okay, so what is anterior lobe? It's also known as adenohypophysis. So this anterior lobe on histology, when you see, you'll see they are round to polygonal cells arranged in cords. Okay, and they have a fibrovascular stroma. I'll also show you a picture. Okay, so this anterior lobe cells have three types of cells. One is chromophil cells with acidophilic granules. Acidophilic granules means they're like pinkish color. Okay, so majority of this chromophil cells with pinkish granules have they comprise of about 40% of anterior lobe, and they're seen on the lateral wings of the anterior lobe. So what chromophil prolactin. Okay, so they secrete this chromophil cells with pink granules, that is called as acidophilic granules, and chromophil cells with basophilic granules or blue colored granules. I'll show you a picture. I'll also show you use the pointer. You'll be able to understand. This constitutes only about 10% of the anterior lobe. Okay, and I told you the pink colors is found in the lateral sides, and this blue color is seen at the median wedge. Okay, so what does this blue color granule secrete? It secretes it has gonadotrophs, okay, which is a source of follicular stimulating hormone, luteinizing hormone, or interstitial cell stimulating hormone. Okay, it also produces some thyroid stimulating hormone, and it also produces adenocorticotrophic hormone or melanocyte stimulating hormone. Now, this chromophil cells constitutes 50%. Okay, chromophil cells has blue granules and pink granules, so that constitutes 50% of anterior lobe. Another 50% is by the chromophobe cells. Okay, these chromophobe cells are cells, they do not have any granules. Okay, they just cells. You can like you can just see only the nucleus. The cytoplasm does not have any visible granules, and they constitute about 50% of the adenohypophytes. Okay, so they do not have any visible granules, and electron microscopy reveals that they have sparse granules, but on light microscopy, that is, if you see under the microscope, you will see that they do not have any significant granules, like I told you about chromophil cells. Okay, so all the functions of adenohypophysis are under the indirect control of hypothalamus. Okay, how? Because of the blood that flows through the hypothalamus and it reaches the anterior pituitary. So it is not directly controlled by the hypothalamus. It is indirectly controlled because of the blood that flows through the hypothalamus and it reaches the anterior loop. So this is a picture. If you see, all these are like this one whole nest. Okay, if you see that these are the pointer which I'm showing you, they're all pink color. Okay, this is acidophilic chromophil cells with acidophilic granules. These are chromophil cells with acidophilic granules. And these are basophilic granules with basophilic granules. Okay, you know that they're more compared to the white granule, but the more percentage of cells are pink rather than, so they constitute about 40%. This blue color ones constitute only about 10%. Now I'll show you some cells. Okay, so can you if you carefully see the pointer, okay, these are cells which have absolutely no granules. These are the chromophobe cells. Okay, the ones which don't have the granules and are present directly, okay, like just like a bare nucleus, these constitute about 50% of adeno hypophysis. Why am I stressing so much on the type of cells? Because this is a pathology class. You definitely need to know how it looks on a slide. If you need to know if a tumor is arising from anterior pituitary or a posterior pituitary, you need to know the normal type of cells to basically understand if the cells are abnormal. That's why we are stressing so much on how the cells look. This is about cells in the anterior pituitary. So chromophil cells with acidophilic granules, chromophil cells with basophilic granules, and chromophobe cells with absolutely no granules. Okay. So I told you about all the hormones that anterior pituitary secretes. They are the growth hormone, the prolactin, then the follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, adenocorticotrophic hormone, melanocyte stimulating hormone, etc. Okay. So coming to the posterior pituitary or the posterior lobe, okay, it is called as a neurohypophysis. This neurohypophysis, like I told you before, it has direct connection with the hypothalamus, as it's just an outpouching of the hypothalamus and it like a downward outpouch of the hypothalamus. Okay, and it is composed of interlacing nerve fibers, and these nerve fibers have very special type of cells called as pituocytes. Okay, pituitary gland, and these nerve fibers have these glial cells called as pituocytes. Okay, and when you see them under electron microscopy, these have these neurosecretory granules. Okay, and there are two hormones which the posterior pituitary secretes. Both of them are very important. One is called as the antidiuretic hormone or the vasopressin, and another one is the oxytocin. Oxytocin is super important, especially in women. Okay, it helps in lactation. It also helps in during delivery for the contraction of uterus. And vasopressin or antidiuretic hormone, you all know that it helps in the reabsorption of water. Okay, both these hormones are produced by these neurosecretory cells of the pituitary. So what does ADH do? It causes reabsorption of water from the renal tubules. So it is very, very important for maintenance of the osmolality of the plasma. So all of you know that our blood, okay, is made up of the formed elements, or the thick part called as the formed elements, and the watery part called as plasma. This plasma needs there should be the maintenance of osmolality in plasma, and antidiuretic hormone helps in maintenance of the osmolality. ADH deficiency causes a condition called as diabetes insipidus, where there's uncontrolled diuresis, means they start producing large amounts of diluted urine. Okay, polydipsia, that is feeling really thirsty. They keep drinking water. They keep producing large amounts of urine, which is very, very diluted. Okay, what does oxytocin do? There are only two hormones of neurohypophysis or the posterior pituitary. One is ADH, one is oxytocin. Oxytocin causes contraction of the mammary myoepithelial cells. So these myoepithelial cells, they are nothing but smooth muscle cells. When they start contracting, the the lactiferous duct, they start ejecting milk. Okay, so this hormone actually acts on the myoepithelial cells, and they help in the contraction of these myoepithelial cells. Myo means a muscle. Okay, so they are smooth muscle cells which actually line the mammary gland. Okay, the ducts of the mammary gland. So when these ducts contract, there'll be secretion of milk. Okay, so they help in the ejection of milk from the lactating breast, and they also help in the contraction of the myometrium uterus. So women is and this oxytocin is naturally produced it helps in the contraction of the uterus. Only when there is contraction, the baby will come down and the baby can be delivered. Sometimes what happens, synthetically produced oxytocin is also given so that it can do the same work that the naturally occurring oxytocin from the neurohypophysis does. Okay, that is contraction of the uterus, which promotes the easy delivery of the baby. So, pituitary is a very tiny organ. I told you it's about 500 milligrams. Okay, like a small tablet. I told you, like a small white tablet that you can see in your house. It's a tiny organ and it's concerned with a variety of diverse functions. Okay, so what does pituitary basically do? Pituitary, I told you, it helps in the growth and differentiation of cells, and all the hormones that the pituitary secretes. It helps in the differentiation and it also helps in the growth. Okay. So the pituitary gland also can be affected by the same thing. It can be hypofunctioning, it can be hyperfunctioning, okay, or it can have some tumors. Okay, so non-neoplastic can be inflammations, hemorrhage, it can be trauma. I told you it is present in the sella turcica. So any problem with head injury or something can actually cause a problem with the pituitary, and it can also be involved in many neoplastic. Neoplastic means what? Like benign and malignant tumors of the pituitary. Okay, functionally and morphologically, there can be hyperpituitarism, that is excess secretion of the pituitary hormones, hypopituitarism, that is very deficiency of the pituitary hormones, and pituitary tumors. Okay, there can be adenomas, carcinomas, etc. So let's come to what happens when there's too much of pituitary hormone secretion. So it is been given as hyperpituitarism. So hyperpituitarism is oversecretion of either one or all of the hormones involved in the pituitary gland. Okay, it can be because of only anterior pituitary hormones oversecretion, or it can be posterior pituitary, or sometimes it can be a problem with the hypothalamus, which actually continuously stimulates the pituitary to secrete more hormones. So it can be anterior pituitary, it can be posterior pituitary, it can be both, or it can be because if there's no problem with the pituitary, there can be some overstimulation by the hypothalamus. I told you hypothalamus directly stimulates the posterior pituitary, and it stimulates the anterior pituitary by blood which reaches the pituitary from the hypothalamus. Okay. So for all practical purposes, whenever we see a condition of hyperpituitarism, we think that it's because of some tumor, okay, of the pituitary called as pituitary adenoma. Very rarely, it can also be a carcinoma. So hyperfunction of the anterior pituitary is generally, okay, it's not always, it's generally because of hormone secreting pituitary adenoma. Okay, so hyperfunctioning of the anterior pituitary can be there can be three important syndromes. Okay, one is gigantism and acromegaly. The other one is it produces prolactin. Growth hormone excess can be gigantism and acromegaly. Uh, Prolactin hypersecretion can be hyperprolactinemia and Cushing syndrome because of adenocorticotropic hormone. Now, what is gigantism? What is acromegaly? Both are because of increased secretion of the pituitary gigantism. It occurs closure epiphysis and the diaphysis, and diaphysis is the long shaft of the bone. Okay, so when the growth plate closure hasn't occurred, that is epiphyseal closure hasn't occurred, and when the pituitary hormone continuously goes and acts, there will be gigantism. Okay, so it can be seen generally in people where the growth plate is not closed, that is epiphyseal closure has not occurred. And who are they? They can be young boys and girls, pre-pubertal boys and girls, where the epiphysis is actively making sure that they grow. Okay, and it is less frequent than acromegaly, because gigantism is usually seen in young children. Okay, so these kids actually present with excessive and proportionate growth of there's enlargement of as well as thick and because look like giants, that's why it's called as gigantism. Okay, and there is increase in the height and there is enlarged thoracic cage also. Okay, what is acromegaly? Acromegaly is the same, there is increased secretion of the pituitary gland, but it is after the cessation of the bone growth, that is it is usually seen in adults. Okay, acro means extremities, and acromegaly means there's increase in the growth of extremities. Okay, this is more common than gigantism. Here there's enlargement of the extremities, that is enlargement of hands, enlargement of feet, very too. There is prominent supraorbital ridge, and there is prominent lower jaw also, like this protruding kind of jaw and very big supraorbital ridges. Supraorbital ridges are like behind our eyebrows. Okay, so these people actually end up having prominent supraorbital ridges. They have a very protruding jaw. They have very large extremities. Okay, and they have coarse facial features. They also have big tongues. Okay, and the tongues cannot even be placed inside the jaw, so they have like they can get, you can see that they have like really huge tongues, because of which they'll have marks on the sides of the tongue, which are made by the dental that is their teeth. Okay, so they have enlargement of tongue and lips. They also have kyphosis and thickening of the skin. Okay, and they're also associated with some other hormonal excess, like because it cannot only not only the growth hormone, even the thyroid hormone gets stimulated. So they'll have thyroid toxicosis, and then they'll have gonadotrophin insufficiency, which causes amenorrhea in females and impotence in males. Okay, so gigantism and acromegaly are all both of them are because of this increase in the gigantism is before the epiphyseal closure, whereas acromegaly is because after the epiphyseal closure. So acromegaly you only see like very enlarged extremities and coarse facial features, etc. Okay. Another hormone that anterior pituitary secretes is the prolactin. All of us know what is prolactin. It helps in lactation. Okay, ಏನಾಯ್ತು? Okay, so this whenever this excess prolactin is secrete, it's called as prolactinemia. Okay, there's excessive production of prolactin, and it's usually whenever usually means it's not 100%. Majority of the times this hypersecretion of the prolactin is because of a small tumor called as prolactin secreting adenoma, also known as prolactinoma. Okay, and this results from the hypothalamic inhibition of prolactin secretion by certain drugs. Okay, it can be also the side effects, like when you take chlorpromazine, methyl dopa, etc. So it can be because of these negative feedback, because of which there's hypersecretion. What happens when there's excess secretion of prolactin in females? Okay, it causes something called as amenorrhea galactoria, means they won't be they won't have regular menses, they'll have infertility, but they'll start expressing breast from the milk. Okay, this is nothing to do with pregnancy or postpartum, but female, because of this tumor which is there, like prolactinoma, they have amenorrhea, that is they won't have any menstrual cycle, regular menstrual cycle, even though they're not pregnant, or even though they've not just delivered, or nothing to do with pregnancy, but still they'll be secreting breast milk. Okay, this is because of a tumor in the anterior pituitary called as prolactinoma. Okay, in males also, this prolactinoma can occur, and it causes impotence and reduced libido. What is impotence? Impotence means erectile dysfunction, and libido means it is reduced sexual desire. Okay, so clinical features can be because of associated inhibition of gonadotropin secretion, or with the interference of gonadotropin. Now, this is about prolactinoma and then growth hormone excess. Now, coming to Cushing syndrome. Okay, so another hormone that the anterior pituitary secretes is the adenocorticotrophic hormone. So, whenever there's increase in the pituitary dependent adenocorticotrophic hormone excess, it causes Cushing syndrome. Again, the most common cause is by a tumor. Adenoma is not a malignant tumor. Adenoma can turn malignant, but most of the adenomas are well circumscribed benign tumors which are functional. That is, they keep secreting hormones. Okay, so this is also by a hormone by a tumor called as corticotroph adenoma. Now, what happens when there is hyperfunctioning of the posterior pituitary? So, we saw that anterior pituitary, when there is hyperfunctioning, it can cause prolactinoma, it can cause growth hormone excess, causing gigantism or acromegaly. It can also cause Cushing syndrome, that is, excessive secretion of adenocorticotrophic hormone. Now, what happens when there is hypersecretion of oxytocin, or when there's hypersecretion of ADH? Okay, it causes a condition called as inappropriate release of antidiuretic hormone, where there's excessive secretion of antidiuretic hormone. So I told you antidiuretic hormone helps in um, helps in the reabsorption of water. So there's passage of concentrated urine due to increased reabsorption of water, and there's loss of sodium in the urine. Okay, and that leads to hyponatremia. So a hyponatremia might have its own side effects, and there's hemodilution because there's so much of water being reabsorbed, and there's expansion of the intracellular and extracellular space. Okay, because of increased fluid which is being reabsorbed. It ADH inappropriate release of ADH can be because of the pituitary, or because of some other paraneoplastic examples. The lungs of this tumor can secrete ADH. Okay, so that then also there can be excess of ADH. So inappropriate release of ADH can occur also in conditions like paraneoplastic syndrome, like oat cell carcinoma, small cell carcinoma of the lung. It can be because of carcinoma in the pancreas, and some other carcinoma, lymphoma, etc. Very less common causes are lesions of the hypothalamus, such as trauma, hemorrhage, meningitis, which causes ADH hypersecretion, because there is no feedback from the hypothalamus. There's no problem with the pituitary, but there is no stimulation from the negative or the positive stimulation from the hypothalamus, because of which continuously this pituitary is secreting more and more and more hormones. Okay, it can also be rarely by pulmonary diseases such as tuberculosis, lung abscess, where they can cause overproduction of antidiuretic hormone. What is precocious puberty? Okay, the tumor in the region of hypothalamus or pineal gland causes something called as precocious puberty. Precocious puberty means much before their age they attain puberty. Okay, this it results in premature release of this gonadotropin, and very early, usually in women, in girls, the pubertal age is about 12 to 14 years, 12 to 14, 12 to 15, sometimes even 16. But here, less than 9 years only, they attain their puberty. It's because of premature release of these gonadotropins. They develop premature development of genitalia, both in males and females, growth of pubic hair, axillary hair, etc. And in females, even though they're like just 7 or 8 years old, they have breast development, they start getting breast buds, and they start having menstrual cycles, okay, much before they turn 8 or 9 years old. All these were pituitary excess. Okay, now let's come to what happens when pituitary hormones do not secrete the hormone at a normal, that is hypopituitarism. Okay, when they do not function normally, it's called as hypopituitarism, where they secrete very less hormones. So hypophyseal hypofunction can be because of some problem with the anterior pituitary, where majority, like 75% of the anterior pituitary is lost or destroyed, or it can be a tumor which is sitting on it, which is destroyed, which is not making it secrete. Okay, or it can be lesions in the anterior pituitary, like I told you, tumor, anterior adenoma, I mean, non-secretory adenoma, metastatic carcinoma from somewhere else, some tumor is going and sitting, which prevents this anterior pituitary from secreting hormones. So two important syndromes are panhypopituitarism and dwarfism. Pan means what? Pan means all. Uh, Panhypopituitarism means all the hormones of anterior pituitary are affected when. So this is panhypopituitarism. Um, it causes non. It can be because of chromophobe adenoma. It can cause Sheehan disease and empty cella syndrome. Just give me a moment. So now I already told you about what happens when there's too much of hormone secretion. Now I'm telling you about what happens when there's very little hormone secretion. Very little hormone secretion from the pituitary can cause something called as hypo either panhypopituitarism. Okay, so let's learn about what is Sheehan syndrome. Okay, Sheehan syndrome and Simmons disease are both similar. Sheehan syndrome occurs in women. Okay, it's because of necrosis of the pituitary because of postpartum injury. That is Sheehan syndrome. Whereas there is necrosis of the pituitary, but it is not in women. It is seen in men. Okay, that is called as Simmons disease. Both of them, there is necrosis of the pituitary, but in Sheehan syndrome, it's because of pregnancy, that is postpartum, after delivery, because of the loss of blood supply. Pituitary keeps enlarging during pregnancy, because of which the sudden loss of blood supply or hypotensive shock can lead to the necrosis of pituitary. That is in Sheehan syndrome. Okay. Other mechanisms which causes Sheehan syndrome can be because of disseminated intravascular coagulation, or it can be because of traumatic injury, or because of excessive hemorrhage, etc., following postpartum, that is following delivery. Whereas Simmons disease is also necrosis of the pituitary, but it occurs in males, and obviously there is no pregnancy associated with males. So it is just necrosis of the pituitary, which is seen in males. It's called as Simmons disease. Um, Patients who have long-standing diabetes have a greater risk of this necrosis of the pituitary. So what happens? How do they realize that the patients have this necrosis of the pituitary? Soon after delivery, obviously because of hypothalamic pituitary ovarian axis, a lot of hormones need to be secreted, and prolactin and everything should be activated, and okay. So a lot of hormones, and naturally, soon after delivery, the lactation process should start. But when there is no lactation, failure of lactation after delivery, the surgeon will usually think of Sheehan syndrome, where there's deficiency in prolactin. Okay. um, Other symptoms can be loss of axillary and pubic hair, loss of menstrual cycles called as amenorrhea. Then they can be sterile, that is inability to conceive, and loss of libido, or loss of sexual desire. Okay. They can also have, along with problems with this, they can have deficiency of thyroid stimulating hormone and adenocorticotrophic hormone. And I told you it's necrosis of the pituitary. So there's early stage, there's ischemic necrosis and a hemorrhage. Whereas if you see at a later stage, this necrosis, this necrotic tissue is replaced by a fibrous scar. What is empty cellar syndrome? I told you that pituitary is, present in a space, okay, in the base of the brain called as sella turcica. So whenever there is empty sella, that is when there is no pituitary present in the sella turcica. So it is characterized by empty sella and features of panhypopituitarism. Pan means all, hypo means low, pituitarism means all the hormones of the pituitary are deficient. Okay. It can be because of herniation of subarachnoid space into the sella turcica, because of which, you know, it replaces the pituitary and it creates an empty sella space, or other causes like Sheehan syndrome, or when there is a tumor called as adenoma, or there's some problem with the pituitary because of side effects of irradiation, or there is some tumor which is producing so much of hormones that the doctors themselves have removed it, surgical removal of the gland because of any adenoma or carcinoma. So what is pituitary dwarfism? Okay, here there is severe deficiency of growth hormone in children before the growth is completed. Okay, here there it. I told you in growth hormone deficiency, uh, in because before the epiphysis fuse, they'll have proportionate. Everything will be proportionate, but here it will not be proportionate. Okay, it results in retarded growth and pituitary dwarfism. Most commonly it's growth hormone deficiency, which is inherited as autosomal recessive. Okay, less commonly it can be because of some tumors like pituitary adenoma and craniopharyngioma, or it can be because of infarction because of less blood supply to the pituitary. Usually appears after 1 year, and there's proportionate retardation in growth of the bones, normal mental age, state of age, and poorly developed genitalia. But they do not have any puberty, or they do not have episodes of hypoglycemia, which is very different from hypothyroid dwarf called as cretin. Okay, cretin is disproportionate, and there is achondroplasia, and there is mental retardation. Whereas in pituitary dwarf, they have normal growth of bones, they have normal state, mental state, and only they do not have do not have good developed genitalia, and there is delayed puberty. So it has to be differentiated from thyroid hormone deficiency during pregnancy. There also the kids will look like dwarfs, but everything will, the facial features and everything will be disproportionate. But here in growth hormone deficiency, everything will be proportionate. Okay. Hypofunction of the posterior pituitary and hypothalamus. Posterior pituitary secretes two hormones. One is ADH and the other one is oxytocin. When ADH is deficient, there's excretion of very large volume of diluted urine, because there's no reabsorption of water, and the specific gravity is very, very low. Okay, so there's polyuria and polydipsia. Okay, and then when there is um, oxytocin, whenever there's hypersecretion of oxytocin, there'll be smooth muscle, there'll be excessive stimulation of smooth muscle. Okay, so I told you. Sorry, when Hi guys, I'm sorry for the discontinuity. Very bad network. Okay, so let's come very briefly about pituitary adenomas. Okay, pituitary tumors, the most common pituitary tumors are pituitary adenomas, and depending on how they look on the slide, okay, and how they look according to the H&E staining, they are called acidophil, basophil, and chromophobe. Like I already told you at the beginning, what is acidophilic? That is pink granules, basophilic is blue granules, and chromophobe adenomas where they're bare nuclei without any granules. So when the whole tumor is composed of, pink granules, it's called acidophil adenoma, or basophil adenomas, blue granules, and chromophobe adenomas if it's composed of cells which have, cells which have no granules and just bare nuclei. So they can be very small, less than 1 centimeter or 10 millimeters in a size, and they can be very large also. Though the pituitary itself is like kutti small, less than 5, yeah, less than 1 centimeter. This can grow very large. Okay, it can be soft, spherical, and encapsulated. And it usually, when you see them on microscopy, it contains one of the types of cells. It can be either one of the type of normal appearing cells of the anterior pituitary, that is acidophilic cells, basophilic cells, or the chromophobe cells. So here you see this picture. There's like a big tumor here which is growing at the base of the brain, and it's actually compressing part of the brain. And it is quite well circumscribed. You can see that it has good margin. So this is the pituitary adenoma. The cells can have different type of patterns: diffuse pattern, sinusoidal pattern, and papillary pattern. Okay, so this is a picture of pituitary adenomas. You can see that some of the cells have nice pink granules around them, and some of the cells have just like bare nuclei, which is the chromophobe type of cell. Okay, so these are the different patterns that you see. One is a sinusoidal pattern. One is the tumor cells are present in cords and sheets. Some of them have a nice fibrovascular stroma. Okay, they're around a blood vessel, so they have a fibrovascular stroma. So depending on what hormone they produce, it can be prolactinoma, where it produces prolactin hormone, and they present with hypogonadism and galactorrhea, that is increased milk secretion. It can be somatotroph adenoma, where there is growth hormone excess, and it causes acromegaly or gigantism. It can be a mixed prolactinoma and somatotroph, where both growth hormone and prolactin are secreted in excess, where it can cause galactorrhea, hypogonadism, and acromegaly. It can be excess secretion of ACTH because of corticotroph adenoma. They present with syndrome, Cushing syndrome like features. It can be because of gonadotroph adenoma, where there's excess follicular stimulating hormone and luteinizing hormone. Because of this, there is a negative feedback and they have hypogonadism. Okay, it can be extrathyroid hormone, where it is because of tumor control patients. It can be a mixture of all, like multiple hormones being produced. Okay, so most common pituitary adenoma can be prolactin secreting, called as lactotroph adenoma, and then a growth hormone secreting adenoma, and a corticotroph or ACTH secreting adenoma. Sometimes it can be mixed also, where they secrete multiple hormones. um, Okay, and there's something called as hypothalamic suprasellar tumors, or one of the most common tumor is the craniopharyngioma. This tumor is arises from the remnants of the rat case pouch, and this craniopharyngioma is a tumor which is commonly seen in children and young adults. Okay, and it can also be seen in the other extreme age group of people who are above 65 years or more. So it is the two peaks of age group. One is very young children, one is older people more than 64 years. Because this tumor is benign, but because it starts growing, it compresses all the adjacent structures. So it is benign, it is well encapsulated, and it also sticks or adheres to the surrounding structures, and it has a typically cystic or reddish gray mass, and they often encroach on the optic chiasma and the cranial nerve. So the patient actually present with loss of eyesight. Okay, it can be two types: adamantinomas matis craniopharyngioma and papillary craniopharyngioma. Okay, histologically, that is when you see them on slide, you can see that there is nests and cords of wet keratin and stratified squamous epithelium embedded in a spongy reticulum. Okay, so there is wet keratin, and keratin means like how you all see in squamous cell carcinoma, but here the keratin is wet keratin, and it is compact, and there is lamellar keratin formation. Okay, and there is also some cystic degeneration, and the cystic areas. What is a cyst? Cyst is nothing but a fluid filled cavity. Here also there are a lot of cystic areas which form in your pharyngeal in this cyst, no, there's buildup of bull is made. So when surgeons actually operate on this, when they actually when this tumor exudes this brownish machine oil appearance, they'll have a diagnosis in mind even before they send it to the called as craniopharyngioma. So this is a picture showing wet keratin and cords of squamous epithelium. Okay, papillary craniopharyngioma shows solid sheets and papillae. That's why, because they have papillary structures, they're called as papillary craniopharyngiomas. Then there is another tumor called as granular cell tumor or choristoma. Choristoma is something which is not indigenous to that particular place. Okay, so this is composed of a mass of cells having granular eosinophilic cytoplasm, and it very similar to the cells that is seen in the posterior pituitary. And because it arises because of developmental anomaly, it is called as choristoma. Choristoma generally means, you all have read what is choristoma. It is some thing which is not indigenous to that place. Okay, so today's class I finished about pituitary. Okay, I thank all of you, though I'm not able to see you, I'm not able to hear any of your voices. Please go back and read today's class. Majority of the portion was taken from from Harsh Mohan, because the introductory part of endocrine is given very well. Another endocrine, the next thyroid, you have to read from both Harsh Mohan and Robbins. It's given very beautifully in both. And this diabetes, okay, the endocrine part of pancreas, you have to read it only from Robbins. It's given very beautifully in Robbins. So my next three classes will be thyroid, then briefly about adrenal, and then diabetes. Diabetes will require almost like an entire class. So thank you so much. I'll see you next Wednesday. Okay, thank you. Bye bye.